And we will have Dr. Mary Beth Maritim with us and Professor Gidanga. I'll let them introduce themselves and then they can proceed with the session. Thank you very much again for your patience.
Good afternoon, everybody. My name is Dr. Mary Beth Maritim. I'll be presenting on the immune system, the immunology of SARS-CoV-2 infection. I'm based at the University of Nairobi and Kenyatta National Hospital and Bagathi Hospital as well. Nancy, am I going fast? I can share my screen.
Yes, you can share your screen. We can hear you well.
Okay, thank you. Just 1 minute. So I'm starting the presentation now. So I was asked to talk about a little bit about the immunology or immune responses to SARS-CoV-2 infection. So I have to confess I'm not an immunologist, but I'm an infectious disease specialist. And as part of our training, we have to understand the immunology. So I will be presenting about the immune responses to SARS-CoV-2 infection, and just I have no conflict of interest to declare. This is the outline of my presentation. It's a very short presentation, I think, to be the preamble to the discussion by Prof. Gidanga. And I wanted to put this slide here just to bring us into perspective about the magnitude of the burden of disease currently, globally, and even in Kenya. Globally, we have 14.5 million cases confirmed and more than 600,000 deaths. And the leading countries are indicated there on the left, with US leading, followed by Brazil, India. And in African countries, you can see South Africa is catching up with the rest. So because initially we had been told that we may be free of, escape the burden of the infection, South Africa, which is an African country, has already joined, is among the top 5 countries. So it may be impossible for us to escape the burden of the disease. On the right here, we have the statistics for the Kenyan outbreak, and this is up to yesterday, the situation report, where so far we have cumulatively 13,000 cases and 234 mortalities. So this is just the map of Kenya to show the magnitude of the cases, and Nairobi has the highest burden of cases, followed by Mombasa. Initially, Mombasa had a higher attack rate compared to Nairobi, but Nairobi has overtaken Mombasa and currently is leading with about 153 persons per 100,000 infected by COVID-19. So we are watching that space keenly, but so far, most of the counties have reported cases, with just a few counties, about 3 or 4 counties not having cases so far. West Pokot, I think Baringo. These counties within the North Rift don't have cases, but again, it may be a factor of surveillance. In terms of the case distribution, most of the cases are among males, and we can see in this bar graph, as well as even the pie chart. So 67% of the infections are among males. This is the cumulative cases and the mortalities, again, which I had already highlighted, more than 13,234 mortalities. I put this here because it may come up in the discussion about the food aspects, but in terms of this that have have contributed to the mortalities, we are missing data for a large proportion of the mortalities, which is being compiled still. But of the 126 out of 234, the commonest comorbidity is hypertension, followed by diabetes, and then the others below there. And we can see some conditions that we were fearful about, like HIV, contributing to few numbers to the mortality. But again, this is too early to tell, because as the cases keep on going up, then this again might change. So coming to the immune aspects of SARS-CoV-2, which is the etiological virus for COVID-19, there are several processes that we have to understand. And one of the things we have to appreciate is that this is very dynamic information. There's still a lot of paucity of knowledge out there, and a lot of research is being sort of focused in this area to understand the pathogenesis, the immune response, to determine the correlates of protection in following infection. Most of the evidence has sort of been informed by previous studies that were done for the other coronaviruses that cause severe morbidity and mortality, particularly SARS-CoV, which I like to call one, the original SARS-CoV, which caused the epidemic in 2002 to 2003, and then MERS-CoV, which again caused an outbreak around 2012, and then now this SARS-CoV-2. So a lot of the information has been inferred from the previous human coronaviruses, particularly MERS and SARS, to sort of inform most of this. And therefore it was just to go ahead and confirm. So we know currently that for the viral entry, it uses the angiotensin converting enzyme type 2 receptor, which is found in significant number of organs within the human body. And it requires that as a receptor to enter the cells within the respiratory tract and other areas where it causes disease. So there's an attachment process. And then following attachment, there's entry of the virus into the epithelial cells within, for example, the lung alveolus. And then once it's within the cytoplasm, then it's an RNA virus. It quickly starts to replicate, produces viral RNA, and then other viral proteins, and then is assembled. And then now there's release of virus, which is an enveloped virus that we can see there. So this is the normal replication that is there for SARS-CoV-2. In the process of this replication, it undergoes what is called pyroptosis, or rather, pyroptosis is a process that has been described in cytopathic viruses, where as a result of the replication, it produces cytokines and other inflammatory markers that attract inflammatory cells to come to that environment. And as a result of that, it can actually result in like cell death. That's the infected cell actually dies, but it's a factor of like attracting the inflammatory marker. So it produces those markers, the chemokines, and thereafter it undergoes pyroptosis, which we shall see later. So this is a process of viral replication. And following the viral replication, because the virus is a foreign body, as a result of that infection, the virus is able to attract inflammatory markers, pro-inflammatory markers initially, and other chemokines that cause the immune mediators to come to that site. And some of these markers that are secreted, or chemokines and pro-inflammatory cytokines, include interleukin-6 and all these other inflammatory markers, and even interferon. And all these are able now to attract the cells of the immune response, where we have both the T cells as well as the B cells, which are the effector cells. So within the T cells, these are able to influence the cytotoxic T cells. So CD4, which is mainly a helper T cell that sort of is able to mediate between both the humoral as well as the cell-mediated immunity. And then we also have the CD8 positive cells. So in following infection, there can be two outcomes following even the inflammatory response. You can have an inflammatory response that's able to come on site and be able to eradicate the virally infected cells, which would be a normal response. However, in SARS-CoV-2, what is being seen is that in certain patient populations, you can have an aberrant immune response that then becomes exaggerated. And that is now what has been attributed to causing the severer forms of disease and resulting in mortality in certain patient populations, particularly patients who are older, patients with hypertension and other comorbidities, and certain patient group, but it's not fully understood. Even within patients who have similar comorbidities, some of them are able to survive and some of them have a poor outcome. So this is just what it is illustrating. We'll start on the right side where we have what is called the healthy immune response. So in the healthy immune response, you have three outcomes. The infected cells are rapidly cleared. The virus is inactivated by neutralizing antibodies, and there's minimal inflammation and lung damage. So this is an outcome we'd like for most of our patients because it has a good outcome, and these are the patients who are likely to survive the disease. And there are various processes that are involved in that there is production of neutralizing binding antibodies, and some of these have been thought to be antibodies against the spike surface antigen or receptor that's on the virus. And those are beneficial because they bind other virions and therefore attenuate the infection and prevent like ongoing infection. The alveolar macrophages are also attracted to the site. Remember we talked earlier on about the pro-inflammatory cytokines and other chemokines. Once the alveolar macrophages are attracted to the site, they are able to clear up the neutralized virus and therefore stop ongoing infection. Again, some of these alveolar macrophages recognize and phagocytose apoptotic cell, and therefore the cells which have the virus are therefore like dealt away with or removed through that process, through using the inflammatory response. And here we again see the role of the CD4 positive T cell and the CD8 positive T cell. The CD8 is mediates the cytotoxic aspect. So the CD8 T cell recognize and eliminate the infected cells, while the CD4 positive T cells again ensure link it up with the humoral response and again mediate the production of the neutralizing antibodies. So this on the right side is a favorable immune response. On the left side, however, we have what is called the dysfunctional immune response. And in this one, this is where as a result of the immune response, then you have collateral damage where there's so much damage to the lung as a consequence of that. So there's excessive infiltration of monocytes, macrophages, and T cells into the lung parenchyma. There's systemic cytokine storm, there's pulmonary edema and pneumonia, and then there's widespread inflammation and multi-organ damage. And this is a defective immune response. So it was started off by the pro-inflammatory response that we had talked about earlier. But as a result, you get a lot of the pro-inflammatory cytokines together with some of the anti-inflammatory cytokines, and you now get overreaction of that. And this is what you call the cytokine storms, where there are lots of inflammatory chemokines that are produced, and as a consequence, you get damage to the alveolar lungs. And this is really where those patients who are going to die, the ones who develop critical acute respiratory, they develop acute respiratory distress syndrome, they go into severe, what we'd call in terms of our clinical classification of COVID, these are the patients who develop critical illness and they get into ARDS, they need ventilatory support. Some of them go on to develop multi-organ failure. And even in ongoing studies, some of the organs that have been looked at have a lot of inflammatory markers in the milieu. And this is thought to be an extension of what is happening in the lung, also happening in different organs within the body. And the patient therefore has a poor outcome. And for those of you who have been listening in on the webinar, these are the ones who, when you do the CT scans, you actually find like there's a complete ground glass appearance in both lungs, and therefore the patient, there will be a lot of lung damage that impairs oxygenation, and therefore even with high levels of oxygen, you are not able to ventilate the patient and achieve oxygenation of the blood. So in terms of just explaining this pathogenesis, in most individuals, we know currently, in terms of the statistics, a large proportion of our patients are asymptomatic. In our local data, more than 50% of the patients would be asymptomatic, and followed closely by patients who have mild disease. And currently, the patients who develop, let's say, moderate, severe to critical illness are just about 15 to 20%. So in most individuals, recruited cells clear the infection in the lungs, and the immune response recedes and the patients recover. In some patients, the dysfunctional immune response occurs, which triggers a cytokine storm and mediates widespread lung inflammation. And multiple viral and non-viral structural proteins antagonize interferon responses. And this interferon antagonism aids viral replication, resulting in increased release of pyroptosis products that can further induce the aberrant inflammatory response. So interferon is one of the anti-inflammatory cytokines that would be like the good cytokine, but in this case, it's overwhelmed by the other cytokines, and therefore you have an adverse outcome. And that's the definition of pyroptosis there, where you have highly inflammatory form of programmed cell death that is commonly seen with cytopathic viruses, of which SARS-CoV-2 is one of them. So this is just a pictorial representation of all that we've been talking about. So you start off with viral response phase. This is where the virus enters the body, is replicating in the upper respiratory tract. You have the early disease that is mainly upper respiratory tract, comprising of mild constitutional symptoms, high fever, dry cough, diarrhea, headache, and different manifestation. But basically, it's a mild form of disease, most often upper respiratory tract prodrome. Some people even we know could be infected but may not develop some of these symptoms. And following the viral response, then as the virus declines in the body, then you have the host inflammatory response, which is really the second phase of the illness, where now you have the inflammatory response that was coming in to fight the virus, then goes haywire, and then now you have ongoing damage in the patients. And in the patients who develop severe form of disease and critical illness, they go on to, it's an exaggeration of the host inflammatory response. And like I said earlier, some patients we know would be at increased risk of these adverse outcomes, but even within the same patients, it's not clear why certain patients would survive and some patients may not survive. And it may come down to specific genetic makeup within the individual, in addition to maybe being of advanced age or having certain comorbidities. And in terms of, again, there's a time duration so that most of your adverse outcomes would actually occur 2 to 3 weeks after initial infection. So a patient may have had the upper respiratory tract or sore throat or mild symptoms a few weeks before, and then they even forget about that. And then you find patients developing acute onset of difficulty in breathing and hypoxemia if you're measuring the pulse oximeter. And this can occur even within a 2 to 3 week period. And that's why it's important when you're taking the history from the patient to even warn them that these symptoms can occur much later on, because it's really mediated by the inflammatory response. So in terms of the immunology, a little is known, a lot is still unknown. So what is known is that both T and B cell responses against SARS-CoV-2 have been detected in the blood around 1 week after the onset of COVID-19 symptoms. What is currently not known is whether these are protective or not protective, because everybody is looking for antibodies to prevent, or rather to confer some protection. What we also know is that CD8 T cells are important for directly attacking and killing virus-infected cells, whereas CD4 positive T cells are crucial to prime both the CD8 T cells and the B cells. The B cells are the ones that produce the antibodies. The CD8 cells are the ones that kill the virus directly. And that's why I was saying the CD4 positive T cells are important, because they link the two arms of the immune response, what you call the adaptive immunity. So the T4 cells are important because they provide that linkage for the humoral as well as the cell-mediated immune response. The CD4 T cells are also responsible for cytokine production to drive immune cell recruitment. And B cell responses in patients with COVID-19 occur concomitantly with T follicular helper cell responses. And this is noted from around 1 week from the onset of symptoms. So just one point before I move on from this slide. I used this slide a few weeks ago when I was talking about HIV and the impact of COVID on HIV. And what was interesting to note, many of us had expected that HIV is a comorbidity that would have adverse, patients with HIV would have an adverse outcome when they get infected by COVID-19. But it seems currently, we don't have a lot of data, conclusive data, but it seems that the CD4 positive T cells are providing a benefit, because we know that in patients who have HIV, the CD4 T cells are the ones that are impaired. And therefore that attenuated immune response seems to be beneficial in terms of protecting HIV patients from adverse outcomes, because then it's sort of like a semi-functional immune system that prevents them from getting the hyperimmune response that we have seen characterizing severe outcomes. These are, however, what are not known. What we currently don't know is what is the correlate of protection. And when we talk of correlate of protection, this is a marker that has been proven to offer protection in patients who maybe have a specific illness. I'll give an example of measles. We know that in measles infection, once somebody gets is infected by measles and they develop antibodies, those antibodies are protective. And in the case of measles, I believe they are neutralizing antibodies. And this prevents a further infection of measles. And therefore, once we define a correlate of protection, even when you're designing a vaccine, you want to mimic that correlate of protection. You want to stimulate an immune response that will generate that correlate of protection and therefore confer immunity. And this is seen, for example, when we give the measles vaccine, you're able to monitor antibody titers, and therefore can say that somebody who has a certain level of antibodies then is therefore protected from infection, or even if they get measles infection, the antibodies will offer them protection. So this currently for SARS-CoV-2 has not really been delineated, it's not clear. And even with regard to correlates of protection, once we know what are the correlates of protection, then the next question will be the durability. For example, if it's an antibody, we have had cases where even in literature, people are suspecting that people are being reinfected with a second episode of COVID. They're developing a second episode of COVID. So again, the first question will be, what is the correlate of protection? And what makes people to get a repeat infection? Is it that the antibody, for example, if the antibodies are the ones that are protective, is it that the levels are too low to confer long-term infection? So in terms of correlate of protection, for most viral illnesses, it's thought that development of neutralizing antibodies that are specific to the antigenic parts of that virus would be the most important in terms of delineating them. So for example, in SARS-CoV-2, it's currently thought that it may be the anti-spike neutralizing antibody. So an antibody against the spike part of the SARS-CoV-2, but it's not yet conclusively confirmed. Some quotas also are thinking that maybe it's a CD4/8 or CD4 or CD8, maybe the immunity may be the correlates of protection, but it's not yet fairly known. And the reason for the CD4, CD8 immunity is that what is currently known is that lymphopenia has been correlated with severity of disease. So for most patients who go on to develop severe disease, one of the early warning markers is actually when you do the lab counts and you find lymphopenia, then that is a poor prognostic factor that the patient may go on to develop severe disease. And especially if you're able to assay and find that the CD8 subset is the one that is lower. But what has also been noted is that this lymphopenia is reversible within a few weeks in those who recover. And it has been thought that it may be due to sequestration rather than complete ablation. It's not that the white cells are being wiped out, but it may be that they've been sequestered in a certain area and then they are redistributed thereafter once the virus is controlled. So it's not yet very, very firm that it's either whether it's anti-spike neutralizing antibody or CD4 or CD8, but the thoughts are maybe it's a factor of the CD4 or the CD8. The second question or fact that is not known, is whether the T cells are protective against SARS-CoV-2. Again, that has not been totally proven. And if so, what are the key antigens and cytokine effector program to focus on in terms of research to really confirm whether the T cells are protective. The other unknown is that, are all T cell responses beneficial, or are some contributory to the immunopathology and to be avoided? And we've seen from what I've described earlier, the abnormal responses are difficult even to tell, even between people who share the same comorbidities. So again, to go further and see what are these T cell responses that are beneficial, which ones are the harmful one, and how can the harmful one be mediated to reduce the risk of cytokine storms. And then the other unknown is that if indeed the antibodies are the transient and our T cell memory, if T cell memory is more durable, how durable are these antibodies? So this is another very, very important unknown, because some people have advanced the theory that you can use convalescent plasma as therapy. And in convalescent plasma, you're relying on presence of antibodies. But again, we don't know whether these antibodies are really protective. And even then, for what duration will they offer protection? And then again, in those patients who get recurrent episodes, what is it that mediates the recurrence of the infection? And then the last unknown is, what is the mechanism of chronic post-COVID symptoms like fatigue, joint pain, and dyspnea? These are just some of the few. And some of you might have had Richard Quest complaining about what he has. He has poor memory. Sometimes he forgets things. And there's increasing evidence that patients actually who recover from COVID-19 go on to develop chronic symptoms. And it's not really clear what is the mechanism of some of these chronic symptoms. Is it a T cell abnormality, or is it, what are the mechanisms? And this is very, very important, because we know a lot of the new viruses, particularly even some of the hemorrhagic viruses like Ebola, we've noted that they have chronic sequelae, even in patients who recover. So this will be an important thing going forward in patients who recover from COVID-19, because there will be many people who recover, and some of them may go on to develop chronic complications. So my concluding slide is really, I've tried to cover the immunology. There's still a lot of things that are not known. And I know this is an evolving debate, and I know we'll probably have another episode to discuss this, maybe on the webinars. And the knowledge on immune response following this infection is dynamic and evolving, and we need to watch this space and keep on reading. And then more studies are ongoing to try and explain what are the correlates of protection, what are the markers of chronic complications and sequelae, and what are the potential candidates for therapy and vaccine candidates. So I'll stop there, and then maybe we can have the next presentation, and then we'll have the questions thereafter once we finish the two presentations. Thank you very much.
Thank you very much, Dr. Maritim. I think that was a really, really interesting presentation, and the breakdown of the immunity with COVID. And it's been done very simply, such that we can all understand. I'd like to give this opportunity to Professor Githanga to make his presentation.
I'm Jessica, Associate Professor in Hematology and Blood Transfusion at the University of Nairobi. We'll be making our co-presentation with David Githanga, who will introduce himself.
Good afternoon. My name is David Githanga. I'm a pediatrician, public health specialist, as well as a cardiologist. But for purposes of this presentation, I have a little interest, more than a casual interest, in nutrition. And we will present together so that we do not send you to sleep. And we will try, and my internet's a bit unstable, so you'll forgive me if we switch off the video for now.
And what he forgot to say is that both of us are very avid Spirulina producers, and hence our interest in this.
Okay. I'll share the screen for now and then take it on from there. Okay, share screen. And yeah. Right. Are you able to see? Can you see my screen?
Not yet.
Dear. Share screen. Share screen. It's there. Share. Okay, there. Can you see now?
Yes, we can.
You can see the screen. Excellent. Good. Thank you very much. And we're going to be talking about spirulina as a new age superfood. Some of you may be hearing this for the first time. This is the scope of our talk. We will introduce briefly, mention a word that some of you may be familiar with, nutraceuticals. We will talk about what spirulina is and issues of immune boosting, as well as the nutritional effects, which are really intricately related with effects of infections in general, not just COVID-19. I did mention earlier that I'm interested in issues of nutrition, and this is a very critical issue in our country, both for adults and children. Even more specifically, issues of what we call micronutrient deficiency. Nutrition has been known to be a critical determinant of immune responses. And when you have particularly hidden hunger or micronutrient deficiency, you have significant impairment of cell-mediated immunity, heavy lifting that was very well done by Mary Beth. We have dysfunction of phagocytic function, impaired complement system, as well as secretion of IgA, which is an important antibody on the surfaces, as well as cytokine production. Micronutrient deficiency, specifically of iron, copper, selenium, and the others, as well as vitamins there, are known to also influence how our immune responses interact. What is nutraceuticals? You can notice I'm also having a little bit of a problem talking about that. This is a word that comes from two words, nutrient and pharmaceuticals, which all of us are aware about, and a product that's derived from food, which has other benefits, is what we're really talking about in this particular situation, but has also got some other biological therapies. And the diagram on your right-hand side is actually showing this interrelationship between nutrition and physical chemical properties, as well as bioactivity of the compounds we're talking about, specifically spirulina. Now, spirulina has been called a super new age food, and Jesse will talk a little bit about that.
Okay, so the scientific name for spirulina is Athrospira platensis, but we're just going to call it spirulina. It's a blue-green algae and is one of the richest whole food sources available in nature. And it actually has been known to man since prehistoric times, where it was used as a source of protein and vitamin supplementation. The Aztecs actually used to sell it in their markets alongside their animals and their beads and other things. And there was even one Aztec king who loved fresh fish, but the fresh fish was only available at the sea, from the sea, which was quite a long ways away from the mountain ranges. And therefore, it was beholden upon the long distance runners, the marathoners, to run right to the seaside to get the fish and bring it back. And it was reported that halfway through their journey, they'd stop and consume spirulina in order to give them energy. And it has minimal side effects. It is easily digestible, has high energy, and is gluten-free, has low calories and fat. And therefore, it tends to fit quite easily into many dietary plans, whether one is a diabetic, whether one is overweight or underweight, etc. It is a natural food that contains a wide range of important nutrients. It is rich in proteins, and we'll see this, vitamins, minerals, and also carotenoids, which are a pre-vitamin A. It also contains many known natural antioxidants and micronutrients, which David was very keen on, especially in immunological protection. And it also has vitamin E, beta complex, the B beta complex, biochelated iron, and gamma linoleic acid. And many nutritionists, if there are some amongst us here, will know lots of these effects. So I don't expect you to assimilate all this. I just wanted to show you the general composition, and it has that very high protein content. And in some species, it actually gets close to 70% of protein gram per gram oil weight. The carbohydrates, lipids, minerals, and moisture. It has essential amino acids. It also has non-essential amino acids. All these vitamins, minerals, pigments, and enzymes. And later on, when we're talking about some of these critical antioxidant and cancer and anti-inflammatory issues, we will talk a little bit more about those pigments and enzymes. There has been international recognition for spirulina for quite some time now. At the World Food Conference in 1974, held in Rome, Italy, it was declared that spirulina as the best food for the future. There was quite a bit of interest. The WHO hailed it as the greatest superfood on earth. The FAO in 2008 urged governments to reevaluate the potential of spirulina to fulfill security needs. IMSAM, the Intergovernmental Institution for the Use of Microalgae Spirulina Against Malnutrition, also had projects to improve the availability or make spirulina available. And there were actually some projects which were done in Western Kenya. And some of the early studies or some of the early use in Kenya was actually in Western Kenya in patients with HIV. NASA uses spirulina as part of its astronauts' diet. How it is cultured a little bit so that you can see, spirulina is generally grown in troughs, and these troughs contain some of the chemicals that are needed, and it is an algae which will grow and give this greenish appearance. When harvested raw, as you can see in the upper picture that is highlighted, it looks like pellets. And then these pellets, after it has been dried, and you get these pellets, you then can grind the spirulina into a powder. It can further be processed into capsules or even compounded into tablets. So all these forms are available in the market.
You could also actually directly take the spirulina straight off as a liquid. In fact, it has its highest value because the process of drying sometimes gets to lose some of its nutritional value. Now, what's the rationale for evaluation of spirulina in COVID-19? We know that the primary plants, so-called microbes and algae, have survived in the wild for several millions of years, facing very harsh environmental conditions to survive. These particular microbes and algae produce many metabolites, some of which are very useful in combating many of the diseases and including the viral infections. Spirulina species, and there are many species of spirulina that thrive differently in different parts of the world, have shown both immune improving capability as well as actually suppression of viral activities in humans. There's been recent interest, of course, with the whole issue of COVID-19 in looking at spirulina again, afresh as a sort of an addition to the armamentarium that we are developing to combat COVID-19. We just pulled out a few papers here that may be of interest to some of you. Some of the articles are a little bit older, done by some, particularly a Kenyan who lives actually in Europe, who's been actually interested in pushing for spirulina to be made out here. And these other tests that are more recently that have come out with the interest, the surge interest in COVID-19 as a way of mitigating the effects of COVID-19. Jesse, you want to talk about this?
Yes. So COVID-19, what are the immune boosting and nutritional effects that we can see with spirulina? We talked about that high protein content, which goes up to 70%, the vitamins, sulfated polysaccharides, minerals, etc., all which have been known for a long time to boost immunity. And there also have been multiple studies done, including a few randomized clinical trials and systematic reviews, which have brought the suggestion that spirulina may improve several symptoms. They may have also an anti-cancer effect, antiviral, and anti-allergic effects. And some of these compounds, which have proven antioxidant, anti-inflammatory, immunostimulant, and immunomodulatory effects. And from Mary Beth's excellent talk, you saw the high dose of immunity that goes with this disease. And therefore, it would be worthwhile to explore further how can we dampen the unwanted immune effects as at the same time we're strengthening those wanted immunoprotective effects. And some of these chemicals such as CPC or phycocyanin is one of the major bilirubins with antioxidant and radical scavenging properties, which is known also to exhibit some of these anti-inflammatory and anti-cancer properties. Unfortunately, there is no vaccine yet. There still also is no definitive treatment available for COVID-19. Therefore, many experts will recommend alternative measures in order to enhance the immune system and improve the general health. And this is just a common sense sort of pathway to take. And we saw spirulina is one of the most mentioned in the literature. If one searches, you'll find it's one of the most mentioned as an effective natural immunity enhancer for the prevention of any potential infections. And this is way back even as 2002 and even before. And some, Yakut and Salem, have done clinical trials, given there were only few patients, of spirulina against hepatitis C, and they concluded they have potential therapeutic use in helping out these patients with hepatitis C virus infection. It has also been recommended as a food supplement to reinforce antioxidative status. And this was done in patients with HIV-1 infections, and it was shown to have good effect. Another study done, also again in HIV-1, showed that there was inhibition of the viral replication by an extract of spirulina. So the inhibition of replication may not be as good as the drugs that are taken, but you can imagine that there would be an additive effect. And indeed, in some of the studies or some of the use of spirulina in Western Kenya, where they had a plant there, a lot of people who are using it, the spirulina were patients who had HIV. And in animals, it has seen in the mice, it was found that oral intake of spirulina could prevent influenza A virus in mice. And in other infected organisms, other family animal studies done by Chen et al., spirulina was seen to act at an early stage of infection of influenza, and it reduces the viral load and helped increase the survival rate in these flu-infected organisms. So it shows you there has been quite a bit of interest and work in spirulina for quite some time.
Now, in summary, spirulina has been shown to have a fairly high nutritional value. It's all in literature. It's been shown to have high potential as a nutraceutical. It's generally safe, it's been found to be potentially useful in the management of COVID-19, accepting that the studies are recent. COVID-19 is a recent issue. And there is a role for actually doing further studies, not just for COVID-19, but other comorbidities, particularly NCDs, that have been shown to, in some few studies, to actually have some effect, but we need to localize our study. Important to mention is that Spirulina is available locally. At this point, I would like to end this presentation by thanking the organizers of KNH, particularly Dr. Kennedy has been very keen in ensuring that we've gotten our invitations, all of you who stayed in to listen, and all the other people involved in arranging this excellent talk. Thank you very much.
Thank you very much for your presentation. That has been really a very enlightening presentation. I'd like to invite Dennis Tongwe to also give a few comments before we go to the question and answer session.
Okay, thank you very much for this opportunity to join you this afternoon. We are slightly late, so I'm actually going to not take up a lot of our time, but I'll be talking a little bit about aloe vera, which is been known to be an immune booster. And so I'll just share from my screen very quickly. I'm a doctor, but not a medical doctor. My doctorate is actually in theology, but I've been director of a herbal garden for since 2006, but my first degree is in chemistry. I'm representing Professor Thairo, who is my chair, and also a chemist by training. So I'll just go and talk a bit about the health and medical benefits of aloe vera, but I'll not talk about the other benefits. I'll focus more on the immune system, which is basically our conversation for this afternoon. Aloe vera is known by several names, which I'll not go into the details because of time, but I want to go straight into the nutritional benefits. Malnutrition is a main problem in Kenya, which we know. And we know that one of our goals has been to increase nutritional values, particularly amongst young mothers, but also with COVID-19, this has become a much more serious issue. Again, nutrition has been seen as a key cause of illness. And we know that nutrition boosting, as we've been told by the first speaker, is a critical aspect of being able to manage various types of disease. And aloe vera is known to be efficacious in terms of addressing several types of immune systems in our body. Aloe vera contains 75 nutrients of the 200 active ingredients that we need in our body. We have 20 amino acids, 20 minerals, 12 enzymes, 12 vitamins, and 8 enzymes. And I'll just go straight into some of the benefits of aloe vera. It's been known to manage allergies in the digestive system. It's been known for the management and prevention of various diseases, as we mentioned there. But I think of particular note to us is that traditionally it has been used, and also most of our clients or most of our customers have found it very helpful in addressing inflammatory conditions within their own bodies. There's research which has gone into this, which I'm going to share in a short while, but I just wanted to go straight into just one slide here, which I think is helpful for us. Aloe vera is known to help with digestion, is known to help with the inflammatory systems of our bodies, is known to impact the immune systems, is known as a detoxifier, is known for blood cleansing, is known for alkalizing the body. And all this has actually been captured in research, which is well documented And I do have the references which I'll share at the end of this. So my brief comments on this is that aloe vera is a food or a food supplement, what we call a functional food, that can well begin to support the public health of this country if it became a common part of our diet. Now, I'm aware that in Asia, aloe vera is common almost in every outlet, every supermarket, one has aloe vera. But aloe vera can be something that can also be made available to Kenyans, so it becomes part of our normal diet. So that'll be my brief comments, which I'll make. And I'm aware of time, but I do want to recognize that we have a whole lot of research which has been done and gone into aloe vera. And this again can be shared with the host for all of you to be able to back up the research. So thank you very, very much for that.
Thank you so much to all our panelists for your presentations. It's been really, really eye-opening. We'll proceed on to the question and answer session. And I'll start with a question to Dr. Maritim that was asked by Patricia Mburu. And during your presentation, for immunology, they're saying COVID-19 binds to the ACE inhibitor receptors. So is there a correlation between the ACE inhibitor? So the question here is, are those who are on treatment with ACE inhibitor, should they continue or should they discontinue their treatment now that we know that COVID-19 binds to the same receptors?
Thank you for that question. And I think we covered it in one of our Friday webinars. So initially, there was a concern that patients who are on ACE inhibitors would actually have be at predisposed risk for infection, and even more so would be at adverse risk of poor outcomes. And the concern was that normally when you take a drug that is an inhibitor, the normal response physiologically is to have upregulation where you develop more receptors somewhere in other organs, just as a physiological, like a feedback, a negative feedback loop. So what happened, there were studies that were quickly conducted where they looked at patients who were already in the registries and were taking ACE inhibitors to try and see whether they were at increased risk for COVID-19 acquisition as well as even severity. But from those studies, it was actually found that there was no additional risk for patients who are on ACE inhibitors for acquisition or even having a worse outcome if they got COVID-19. So currently, there's no additional risk, and therefore you don't need to substitute your ACE inhibitor for your patient. They can continue on the ACE inhibitor therapy without necessarily having an adverse outcome. When you look at the patients who develop the critical illness that we talked about and have the cytokine storm, it's not really mediated by, it's not because of the ACE inhibitor therapy, but it's thought to be some other physiological mechanism that's not yet fully understood why certain patients get adverse outcomes. And some of these patients were already even noted when during the outbreak of SARS-CoV, the initial SARS-CoV in 2002 and 2003. And they, the Chinese came up with a severity score, which they even named. And therefore, using that initial evidence, they looked out for those, the predictive risk of that severity score. And it has come out to be that even in SARS-CoV-2, the same severity score still stands, where patients with advanced age, having certain comorbidities, being of male gender, would be at risk for having adverse outcomes.
Thank you very much. To all our attendees, as Dr. Maritim has said, you can continue giving ACE inhibitors to your patients and do not discontinue them. And this is to Professor Githanga. So you've said that Spirulina is available locally. So if one wants to get this, where do they get them? This is a question from Cecilia Mwiva. And I'll also ask together with a question from Rose Nyabanda. And once you access Spirulina, so how do you take it? Is it a prescription? Is it something you mix with your tea and porridge? How do you consume it?
Okay, thank you very much for those questions. Cecilia, you can find spirulina in the pharmacies, and we also do supply it when people ask us for it. It will be available, and you'll be able to get it in a powder form or capsule form or tablet format. So it really does not have a dose because it's more supplied as a nutritional supplement. People may take a capsule of 500 milligrams once or twice a day. We always take the powder ourselves because you can mix it in your juice, your yogurt, your food, and you can take like half a teaspoon to 1 teaspoonful in any of these and, make various shakes which contain spirulina. People have also used it in recipes, in their cakes, cookies, etc. So there are many ways in which it can be taken. I can see another, and as I was saying, it's very safe. It's, whether you take 1 teaspoonful, 2 teaspoonfuls, there are very few side effects. One that I might want to mention is if anybody has an allergy to it. And that's why I would recommend if you start it off, start off with half a teaspoonful and then see how it goes for several days. And then if you don't get any side effects, you can continue taking it. Then I can come to, somebody talked about moisture. We do test the moisture in spirulina. One is that we like to keep the moisture low because if you have spirulina with a high moisture content, just like maize with high moisture content, that will encourage fungal growth, especially aflatoxin, which everybody worries about. The second thing about controlling the moisture is that if you have too much moisture, then you're selling more moisture than spirulina. Although it's a small content, it's not very high, usually less than 10%. You don't want to go to high moisture content because that reduces the amount of spirulina that you will actually have.
Yeah, of course, moisture is not good for rains as well because it encourages production of aflatoxin, which is not in your interest. There is a question regarding the experience of moringa and spirulina. We haven't, of course, done those studies, and that's why we recommended that these studies are very, very necessary now, knowing that for those of you interested in nutrition, that malnutrition is actually the biggest cause of immune suppression globally. So this will probably need to be studied robustly, knowing that we need to begin with the healthy person, let alone the person that's already sick at the moment. So the answer to that question is no. Are there other questions for us? We have got different types of superfoods, right? And somebody's talking about different types of superfoods. What are the odds of severe disease and dying from these obese patients? I think there are many things that are not studied in our setup. There's a whole range of what we're calling nutraceuticals that actually need to have robust studies being done. But I think amongst the foods, spirulina has probably got the highest amount of literature to date. But as it relates to spirulina, we need to specifically design studies and look at this even in relation to the comorbidities that are usually being associated with high mortality rate in our local setup. Where can you get it? We said you can get this basically in some pharmacies and in some healthy use sort of shops. We also do grow some spirulina, and we can provide if you get in touch with us. A lot has been talked about. My senior colleague, Dr. Hilda Njuki, use of lemon, ginger, garlic, turmeric, honey in the management of viral upper respiratory tract infection. Comment. Over and above talking about the general effects of food and so on, I do not know that I have any specific scientific answers to this. And maybe that's why we are talking about having more robust control or studies that will inform us going forward, considering that the bulk of our people may not be able to access some of the things we are talking about. And I saw a question from one of our senior colleagues regarding what we do for our rural folks. And that just Kambani. And that's why it's even more important to basically have studies, and maybe Mary Beth and those at the university are able to, maybe we could work together and design studies to actually look at this.
And as we had said before, spirulina actually was used, was it around 19, when was it, 1000 and something, when it had been introduced by IMSAM into Western Kenya. And it was quite known, the Maseno University actually used to package and sell spirulina. Unfortunately, they're not packaging it anymore. Yeah.
Maseno and Kisumu were the ones that actually did start this earlier on, but it's not easy to
it's not so easy to
produce. Yes, it's fussy. Yeah.
Thank you very much for the responses. I'll take a question from Fanny Nelima, and maybe this is also a question that I have received severally, even as you're talking to patients. So you get a patient who's confirmed positive, but they're asymptomatic or they have mild symptoms. So what should you advise them? Because they ask, what should I take? So what would you advise them to take, even while you either send them for home isolation? What do you tell them to take? And I think this is a question that many people are wondering, nutrition-wise or any medication for them to take. To the panelists, maybe we can start with Dr. Maritim.
You want the nutritional, like what food should they take and all that. I think for me, I can talk in terms of the management for this patient.
Hi, Dr. We can't hear you.
Can you hear me now?
Yes, we can hear you.
Yeah, so I was saying, in terms of when the patient presents and they've already tested positive, you'll assess. If they have no symptoms, they really don't have to take anything in terms of medicine. But if they have some mild symptoms, you'll tailor the symptoms based on their presentation, what we call symptomatic. So if they have the dry cough, irritating cough, flu-like symptoms, then of course you can prescribe the antihistamine. If they have a fever, again, you can give paracetamol. In terms of what to eat, what to do at home, in terms of eating, they'll eat their normal balanced diet food that they eat at home. They don't really have to change necessarily their diet, but it should be a balanced diet. For some of the patients, many of them will tell you that, oh, when I have a home, I always take lemon with ginger and all that. So you don't need to discourage them, but keeping in mind that those things may just work by maybe increasing the vitamin C, which is an immune modulator, but may not necessarily be the ones that will cure the COVID or the virus. We don't currently have a specific curative agent. So it's just to advise them that they'll continue what they are doing, but if they have additional symptoms, then they'll take specific treatment for the symptoms. But then again, you have to tell them what to watch out for, because increasingly the patients we are having in the facilities, they're coming with breathlessness. So it's one of the things you have to discuss with the patient, that if they feel that they cannot breathe, that's a bad sign. Most patients even are not coming with fever now. They come with breathlessness. There's no way you'll tell the patient now, look in your mouth, if your tongue is blue. They won't be able to assess that until they come to the hospital. So the most important thing is, if they have to breathe in deeper, if they have to breathe in more rapidly, then those are early warning signs that they have to come to the hospital. But in terms of diet, in terms of symptom management, it's as already I've described. Let me hear the other panelists as well.
Thank you very much, Dr. for your answer. I think that answers a lot of the questions. I'll take a question from Faith Liso and Mbugua Gabriel. And I think this is addressed to Dr. Dennis Tongoi. So the question is, how do we take aloe vera? Do you take it fresh or as juice? And there are many aloe vera plants and drinks in the market. So which one should one take, and how do you know what is fake and what is actual aloe vera? Oh, my apologies. I think Dr. Tongoi has dropped. So there's a question here from an anonymous attendee. Maybe he's male. He's wondering, why is it that more men are affected than women by the COVID-19? Is it because of the androgens, or do men have more ACE2 receptors? So it's a concern to the male species. They're concerned for themselves. So why is it that they're more affected than women?
That's a good question. I don't have any evidence, scientific evidence to say why men are more affected than women. I've not reviewed that in a very long time. Initially, when I'd reviewed, I couldn't find a plausible reason. Some people think maybe it's occupational, that men take more risk and all that, but there seems to be some either genetic or some physiological makeup that puts men at risk. And maybe the androgens may be one of the things. I really can't tell at this point in time. But to the men who are listening, clearly you are at increased risk of even infections. Every day when the numbers are announced, it's the men, and even risk for adverse outcomes. So just be careful as you go about your day-to-day activities. I think the only difference we have seen where perhaps women outnumber men is when you are looking at occupational exposure. And that is really by design, that many healthcare workers, particularly nurses, are of female gender. Beside that, in most like general population and other settings in Africa, in the US, in wherever you are, it's the men that are more afflicted. So I don't have any reason. Maybe by the end of the webinar, if I Google something and find a plausible answer, I'll add on to that. But for now, I don't have a very good reason why men are more at increased risk.
We're almost coming to the end of this session. Thank you very much, Dr. Maritim, for that response. I'll go back to Professor Jessie Githanga with questions concerning spirulina. And many people, Nziku, Vincent, and several attendees are even wondering, so how much does spirulina cost? Yes, we agree it might be a superfood, but can the common mwananchi afford it?
A lot depends upon any value addition that has been done. For example, if the powder has been harvested, crushed, and powdered, and then packaged, it takes quite a bit to package it into, proper packaged containers. So it will go to round about 1,200, anywhere around that range for 100 grams of spirulina powder. The capsule, again, because of the value addition, usually goes about 1,000, from anywhere about 1,400, 1,500 shillings for 30 capsules of 500 milligrams. Of course, if one is buying the fresh spirulina, that's when it's still wet, that one is much cheaper because it hasn't been processed. And then, or if one is just buying the pellets to take and process themselves or take it as it is, that actually would be cheaper as well. The value in processing it into capsules or powder is that one can keep it for longer periods of time as opposed to the fresh spirulina, which should be taken, at that same sitting. And then, of course, remember that you're not taking chunks of it, you're just taking a little bit on a daily basis. So it's not something that you're eating as if it's a whole meal. You're sprinkling it on food or taking it in your milkshake or in your yogurt, etc. Or in your, your shake where you put in your spinach and everything. I hope that answers the question.
Yes, that adequately answers the question. Back to Dr. Mary Beth Maritim, even as we come to the end of the question and answer session. So there's a question here from Dr. Frank Mwangemi, who's asking, what's your view as regards to giving asymptomatic patients anticoagulants such as aspirin? So what's your view? And then apart from like the common risk factors that we know, age, diabetes, hypertension, and cardiac disease, is obesity a risk factor for adverse outcomes? And does it differ from type 1 to type 2 diabetes? Does the risk differ?
Okay, so I'll start with the second question first in terms of the risk factors. So rightfully said, obesity is one of the risk factors, and increasingly, some of the patients we are losing when they are young, when you look at them, they'll not have those risk factors that I've outlined there, but most of them will have obesity, which is with increased waist ratio as a mark of obesity. For most of the patients, sometimes when they come in too sick, then you're not able to get their height and their weight to really determine their BMI. But obesity is a risk factor for adverse outcome and mortality, particularly in young people. So that one has even been observed in our setting. In terms of diabetes, both type 1 and type 2 share the same risk, and particularly even for some patients who are coming in not known to have diabetes, they're being diagnosed with diabetes with COVID. So it's like incident diabetes in the setting of COVID-19, newly diagnosed COVID-19. So there's currently new literature, and there's a registry that has been started globally to try and actually collect data around diabetes and COVID-19. And what was already known even from the original SARS of 2002, 2003, it had already been shown that part of the disease, actually part of the virus has a predilection for the beta cells of the pancreas. And it's thought that the diabetes that is occurring is actually because of direct cytopathic effect in the beta cells by the virus. So in the patients who we are hearing are coming in, not known diabetes, developing diabetes, then that is one of the pathways that has been postulated. So we need to collect more of this data to see. From our experience, clinical experience, we are finding that even the diabetic patients, when they come, they are difficult to manage, requiring high levels of insulin. And some of them, particularly if you're in a resource poor setting where we are mainly in the public sector, even managing the DKA presents a challenge because we normally have a fluid regime that we give. So in certain cases, it's difficult to balance the fluid administration vis-a-vis the risk for ARDS in these patients. And I remember one of the presentations by Dr. Anguche from Germany talking about even the fluid. There was something about dry rehydration. It's like you're rehydrating the patient, but balancing their fluid. So that is really becoming a challenge, and we need probably to revisit that topic about how to really manage the diabetics, because we are struggling with them. Some of them, you give them a little fluid, then it's like their level of dyspnea goes up. And sometimes even in facilities, we may not have access to imaging modalities. We cannot send our patients to the CT scan. Sometimes we don't have portable chest x-ray. So even to have a baseline of how their lungs are looking like even before. So I hope one of these days we can have that discussion, specifically by the diabetes experts, about really how to manage diabetes in these patients, especially in a setting of a resource poor setting. To go back to your first observation, I think it was by Dr. Mwangemi about the use of anticoagulants in patients who are asymptomatic, and he gave an example of aspirin. So just to clarify, aspirin is not really an anticoagulant. We call it an antiplatelet because it acts by inhibiting platelet aggregation. So it doesn't really work as an anticoagulant, because anticoagulants work in a certain manner. When you're looking at your antiplatelets, you're looking at a platelet-rich kind of clot. So we use it more for where you perceive that the patient would have a risk of, it's more useful in the arterial system but anticoagulants work more in the venous system, which are platelet poor kind of clots that are developed in that setting. So in terms of revisiting your question, the current evidence that we have from the literature is more for patients who are symptomatic, who are like patients who fall in the category of severe and critical, and less, we don't have enough evidence to justify anticoagulation for patients who are asymptomatic or mildly symptomatic. And we're watching the space. Should that evidence then be available, then we can recommend that anticoagulation. But for now, anticoagulation is for the patients that I've described, and there's currently no evidence to use aspirin because aspirin is an antiplatelet. Thank you.
Thank you very much, Dr. I think coming to the end of this session, I'll just ask one more question. We've talked about spirulina and its benefits, and there's a question here from Anastasia Cosmas asking, so what are the adverse effects of spirulina? We've said it is very good, so what should someone watch out for even as they're taking the spirulina?
Yeah. Thank you very much. As we've said, spirulina is considered to be generally safe, consumed as a food additive. But in a few people, it's been known to cause headaches or some mild allergic reactions, particularly people who are allergic to seafoods and so forth. Some people may experience some mild muscle pains, sweating, and a bit of insomnia. Of course, for those who are breastfeeding, we do not recommend it unless you run it by your doctor, mainly because we do not know what would happen in a breastfeeding in a young infant who is breastfeeding. But generally, it's considered safe apart from non-specific issues. I think the bigger issue being allergy to particularly seafoods.
Yeah, and to add, there are quite a number of studies, especially in India, where they even added it to infant formula, infant feed, with good outcomes. They found it was very good, well tolerated, and hardly any side effects in small doses for those infants.
I think what's important to mention in spirulina is the way you grow it. Spirulina is an algae, and there are many types of algae, some of which are not safe. And that's why where spirulina is produced is very important. It's constant regular check to make sure that you do not end up with algae that could be potentially harmful is very important. Of course, the salts you use and the water you use is very important. So really control of materials and the processes is important, particularly that this is not something that is cooked before you take it. There are a lot of people who are also grinding green vegetables and so on and adding a little bit of spirulina and selling it as such. So one has got to be a little careful where you are sourcing your spirulina. There is a lot of shortcuts in the market that one has to be wary about.
Thank you very much for this presentation. We've covered the topic of food products and immunity, and it's been really enlightening. I think right now I'll give to all to the panelists to give us their parting shots concerning this topic. We can start with Dr. Maritim. We can't hear you, Dr. Maritim.
Oh, so my parting shot is really, there's so much we do not know about the immunology or the immune processes about SARS-CoV-2. But whatever we already know, I think we can capitalize on that and use it to help us ensure a good outcome for most of our patients. So for patients who have adverse risk factors for poor mortality, then those are the ones we cannot allow them to be managed at home. And we know we currently have the guidelines for home-based care. Therefore, let's make sure that only people who don't have adverse risk are the ones who are being managed at home, but the rest of the patients, we need to link them with a place where they can be safely cared for. Thank you.
Professor Githanga.
We'd like to thank you very much, KNH, the panelists, and all the people listening in on this conversation, because nutrition, since time immemorial, has been very useful. It is key to maintaining health. And we'd like to just emphasize that, especially now, when there's still so much more to learn about COVID-19, maintaining a good nutritional status and immune status is important. And where you're able to use natural products as opposed to having to go and buy something that was manufactured in a laboratory, you're using something that is found in nature, would be beneficial. And that we do really need a lot more studies in this. There's been a lot done in spirulina in diabetics, people with HIV, people with lipids, excessive lipids in their blood. So I think this is some areas that we could collaborate with researchers to look into all these areas besides just only in COVID-19. Thank you.
Thank you very much for your presentation on food and immunity. And I think all the attendees here have really learned a lot. For our attendees, for anyone who requires slides on the webinars that we are doing and any recording to listen to after, maybe when you have a free time, kindly check at the KNH website. Once you go to the KNH website, there's a drop down for COVID-19 and you'll find all the presentations and slides over there, and you'll be able to access them and listen to them and review them later after when you have time. Thank you very much to Dr. Mary Beth Maritim, Professor Jesse Githanga and David Githanga for your good presentation and for just enlightening us on COVID-19, this disease that is very new. We've come to the end of our session. Thank you for everyone who's attended, and thank you to Dr. Kinuthia for providing the platform. Thank you very much. For any queries for CPD, kindly email us on knhcpd@gmail.com and we shall respond to your email. Thank you very much and have a nice day.
Thank you.
Thank you very much.